Hello, everyone. It's a privilege to be invited to speak at the Classificon conference and to join our colleagues from the Czech Republic. And of course, I'd like to thank the organizers for doing a great job and putting all this effort into making this work. So today, I'd like to share with you our ICD-11 implementation journey in Kuwait. Let me take you on a trip to Kuwait, which is a high-income country with a population of 4.6 million. The Ministry of Health is the main funder, provider, and the only regulator of healthcare in the country. We have around 21 public hospitals with an average of 200,000 inpatient discharges per year. English is the language of clinical documentation in our medical records, and funding is through an annual budget. We don't use a DRG system. We use WHO ICD-10 codes for coding discharge diagnoses, predominantly for statistical purposes, not really for reimbursement. So why ICD-11? Well, the beginning was the project to automate our national statistical reporting processes. And since the 1980s, the National Center for Health Information receives an abstract of the paper discharge summary form for every single hospitalization from all the different hospitals. And this includes, among other data elements, the principal diagnosis and one additional diagnosis. This forms the database for hospitalizations data, which we use for national statistical reporting. Now, the project aims to obtain a more advanced minimum data set for every single hospitalization from the electronic medical record systems in the different hospitals, based on a national data dictionary for standardized reporting. And then, using an API, we can centrally access this data from the different facilities. To build the data dictionary, we need to determine the classification system or codes for every one of these data elements. And the most important one, of course, being diagnoses. And the decision was to use ICD-11 for coding diagnoses. That's because ICD-11's features fulfill our national health system needs. For our national automation project, we need a classification system that is electronic and that can help us attain semantic interoperability. To have the possibility of a DRG system in the future, should the Ministry of Health decide to move to one, we would like to have a classification system that is rich in details and that can provide a potential for a DRG system when it is used with its sibling classification, which is ICHI, or the International Classification of Health Interventions. Like many countries, we are challenged with a shortage of medical coders. ICD-11 is clinically meaningful, so it can be used by clinicians, and the codes are available on the system once the clinician documents the diagnosis. So where are we now? Currently, ICD-11 is successfully implemented in the biggest public hospital in the country, in the inpatient wards and the outpatient clinic, for documenting diagnoses by physicians by installing the ICD-11 coding tool into the electronic medical record system. What happens at discharge is the doctor uses the discharge screen to document the diagnosis in free text as they normally would. They then click an icon to access the ICD-11 coding tool. They search for the diagnosis they want, check the search results, and once the diagnosis is saved, they are taken back to the discharge screen, where they get to see only the ICD-11 entity title. Doctors are not interested in codes, they don't want to see them, and we don't want them to see the codes. But in our database, in addition to the free text documented by the doctor, ICD-11 automatically saves the ICD-11 code and a new and special feature in ICD-11, which is the ICD-11 Unique Resource Identifier. And we'll talk about that later in the presentation. So how did we do it? We started with stakeholder engagement. Then we piloted ICD-11 in one department in the hospital. Then we scaled up implementation to the whole hospital. And then we'll discuss what's next. So ICD-11 implementation has four main stakeholders: health information managers, leadership or administration, ICD-11 users, in our case, physicians, and the IT team. The National Center for Health Information is responsible for setting the national standards for coding, for managing and reporting national statistics, and is the WHO family of international classifications collaborating center in the Eastern Mediterranean region. And as such, it is the center of excellence responsible for ICD-11 transition. Leadership commitment is essential to guarantee the formal approvals, resources, and to ensure effective communication between the different stakeholders, not only centrally in the Ministry of Health, but also peripherally in the different facilities. But what about these last two stakeholders? Why would they buy into our project? So transitioning to ICD-11 is a change management process, and it requires effective communication. We need to use tailored, stakeholder-specific messages for persuasion. We need to persuade every one of those stakeholders to take part. So we need to answer the question, what's in it for me from every stakeholder's perspective? Our messages to the doctors were, ICD-11 is user-friendly. It uses a Google-like search. It is made with the contribution of expert clinicians from different specialties from all over the world. It is updated every year to include the most recent scientific content. And it is rich in synonyms and abbreviations and uses natural language processing, making it even more user-friendly. Our messages to the IT team were, ICD-11 is fully electronic. It can be installed on any hospital information system. It can help us achieve semantic interoperability. It can work both online or offline, and it's free. Now, effective communication also involves listening to the other party. So as we piloted with ICD-11, the doctors experimented with ICD-11, and we listened to their voice through a brief user experience survey. We asked them 3 simple questions. Did you find what you're looking for? How easy was it? And the time it took you. One of our main success factors was the multidisciplinary team approach, which involved representatives from all the different stakeholders. And of course, users, physicians in our case, were involved from day one, because users will be more accepting of change when they are part of the decision-making process. Now we come to our pilot. So the aim of our pilot was to test the real-life implementation of ICD-11 by installing the ICD-11 coding tool into the hospital information system and to use it in the inpatient wards by the physicians in a public hospital. To prepare for the pilot, we started by evaluating the current situation. We wanted first to have a common understanding with our users. So we shadowed the doctors as they did the discharge process in the hospital, and we also studied the different fields that they use on the hospital information system at discharge. Then we planned for the pilot, and we did that through a series of meetings that involved the representatives of the different stakeholders, including the National Center for Health Information, hospital administration, hospital IT, and the hospital physicians. And the physicians, of course, being the heads of the medical departments in the hospital and representatives from the different specialties. By the end of these meetings, we were able to reach a clear and practical plan for piloting, and we also decided to narrow down the focus of the pilot to only one department, which is the internal medicine department. Then we prepared the hospital information system. So first we designed a new user interface for documenting discharge diagnoses that made a clear distinction between one principal diagnosis and multiple additional diagnoses. And we also added fields for the ICD-11 entities. Then the hospital IT team attended an online workshop by the WHO on ICD-11 APIs. They were then able to integrate the ICD-11 coding tool into the hospital information system and make it work offline, which was the requirement of the Central Directorate of IT in the Ministry of Health. Finally, the 4th step was training the doctors. That was a big challenge, and we'll talk about training later in the presentation. So during implementation, in the inpatient ward, the doctors used ICD-11 coding tool to document diagnosis at discharge. We provided around-the-clock ICD-11 support by staff from the National Center for Health Information, IT support by staff from the hospital IT team. As the doctors worked, the data is automatically saved into the hospital database and can be accessed in the IT departments. We held regular meetings in the director's office with the hospital administration to discuss and resolve problems immediately. And we also provided our phone numbers at the computer workstations in the hospital so that if doctors needed any support outside the routine discharge hours of the day, they were able to contact us. That way, we were trying to minimize any resistance to change, because whenever the doctors faced any problems, they can contact us and the discharge process would not be delayed. With 241 physicians, 3,900 medical records, and over a period of 4 months, we believe that this pilot reflects the practical aspects of using ICD-11 in a dynamic environment and showing how it can become part of the routine discharge process. Overall, physicians liked ICD-11. They were satisfied, and the positive feedback received from the internal medicine department encouraged the other departments to request ICD-11 implementation. And this looks like Pac-Man, but it's not Pac-Man. It is actually the pie chart from the user experience survey, showing an overall 83% positive response for the user experience survey. And you can listen to the doctors from our pilot speak about their own experience by watching this video on our YouTube channel. We also learned that it's possible to improve ICD-11 content to make it more user-friendly to our physicians. So if a doctor couldn't find a certain synonym or abbreviation that they use in their own practice, we were able to use the proposal mechanism, which is a WHO online platform, transparent platform, that enables all users and experts from all over the world to contribute to improving ICD-11 content. And we've submitted multiple proposals, and I'm happy to say that almost all of them have been implemented and are now actually part of ICD-11. We find it really interesting when the doctors ask for a certain synonym and say, it's not here. And then we tell them, you know, you'll find it in the next update. And in the next update, they did find the synonyms they requested. And that made them more satisfied with their experience with ICD-11. We also saw firsthand the details that we can have with ICD-11 compared to ICD-10. Now let's take a look at this example. So these are two cases from our database, and we can see that they both have the same code, which is the code for other specified pyogenic bacterial infection of the skin. But notice that automatically the title saved by ICD-11 included a different index term in each case. That's because in the first case, the doctor wrote finger infection and selected this option. In the second case, the doctor wrote toe infection and selected this option. Now, both options have the same ICD code, but the doctors are not interested in the codes. The doctors want to see what's clinically meaningful to them, and they have already selected that by clicking the right one, which is the one highlighted in blue. But look at this. Now, this is a new and special feature in ICD-11. It's called a URI. Now, it's in simple terms, it's like a digital code for every condition in ICD-11. So even the conditions that are classified to one code in ICD-11, they will still be able to maintain an individual unique code, which is their URI. Now, the reason this is really helpful is it can help us retrieve data, the original data documented by the doctor, even if the documentation by the different doctors, such as in this case, will lead to the same ICD-11 code. Now, this is especially helpful for rare diseases. They were mentioned in the morning, in the earlier session, because in ICD-10, many of the rare diseases were lumped together under residual categories like other conditions. Whereas in ICD-11, even if they are lumped under other conditions, we are still able to retrieve the specific documentation by the doctor through these URIs. So, ICD-11 data has something for everyone. Doctors only want to see this because it's clinically meaningful to them. Coders and HIM professionals are interested only in codes because they use them for statistical reporting, for DRGs, and so on. Informatics and IT professionals are interested in using the URIs for interoperability of digital health data and many other uses. Now, if you want to know more about our pilot, we invite you to read this open access paper where we share the methodology and the lessons learned. Now we come to training. That was our big challenge. So we conducted multiple in-person training sessions, including computer lab exercises. Now, the computer lab exercises are important because this is how the doctors learn to practically use the ICD-11 coding tool. During these sessions, ICD-11 was presented as a way for documenting diagnoses. Remember, we are training physicians, so they don't want to hear about codes and classifications, not that interested in ICD-11 uses for research, for reimbursement, for statistics, for the greater good. Okay, maybe they like to hear it, but they are not that interested. So the main message during training was, it's a new way for documenting diagnoses on your system. Training was of short duration and was especially tailored to the doctors in this hospital. Usually when we speak to physicians, they are busy and they want to listen to a message that is relevant to them. So when you speak to them using the screenshots from their own hospital information system, they feel like you're training them on something that is relevant to them. We also offered continuous medical education points to encourage the doctors to attend the training. Now, these are points that they use, for example, to renew their license or for promotions and so on. Still, physicians are busy. They may not all be able to attend in person. So we recorded our training material into short videos, training videos, and we used, again, the real screenshots from their own hospital information system to make the training real and to make it seem more familiar. And this increases our chances for persuading the doctors to accept the change. Then we used WhatsApp chat groups to disseminate our training material. Now, this is the main medium used by doctors in the hospital for communication. It was a very effective medium for us to disseminate the training material. But the main challenge is, how do we scale up the practical hands-on computer exercise? And irrespective of the doctor's working schedule, how can they be trained to use the coding tool? So we decided to use virtual simulation, and it's not as sophisticated as it sounds. And here is how it works. So we created a few virtual medical records. These are exercise cases on the hospital information system, not real cases. And the doctors can access these cases to answer some ICD-11 coding questions, let's say, as usual, as they using their username and password as they normally would. They can do that at their convenience, anytime during the day, and on any of the computer workstations. Now, as they sit in front of the computer, they scan a certain QR code on their phones, and this gives them access to a cheat sheet or a walkthrough sheet that guides them through this exercise. And again, this uses screenshots from their own hospital information system and very basic, simple instructions. It is colorful and engaging, and it's as if they have a personal trainer with them whenever they decide to take the exercise at their convenience. The data resulting from the exercise is saved into a special data file in the IT department, and we are able to access that at our convenience for feedback. Then eventually we decided to create our own YouTube channel to share our training material with a wider international audience. So for example, today we spoke about ICD-11 Your Eyes. There's a video on Your Eyes, 9 minutes. There's another video, 10 minutes, on ICD-11 proposals. Finally, after 1 year of piloting and preparation, we were able to reach full hospital implementation, where ICD-11 is implemented in the inpatient wards and the outpatient clinics in all the departments in the hospital. I've talked a lot already, so I'm going to touch briefly on the challenges and future considerations. So for our national statistical reporting, we plan to continue with ICD-10 in parallel with ICD-11 until all the hospitals move to ICD-11. There is no duplication here because, in our case, ICD-10 happens in the medical records by the coders, whereas ICD-11 happens in the inpatient wards by the doctors. And if anything, the ICD-11 used by doctors in the ward has made the diagnoses seen by the coders in the medical records more comprehensible, so it makes their life easier. The WHO has recently released morbidity tabulation lists, which we are experimenting with now, but we are yet to understand how to analyze data on post-coordinated clusters that result from ICD-11. Now, regarding procedure coding, ICHE, or the International Classification of Health Intervention, is almost ready, and there is an API that is ready to be installed on our hospital information systems. But there is yet to be a DRG that includes both ICD-11 and ICHE for us to use. Now, because we don't use a DRG system, we have a more liberal approach towards trying these new classifications. Finally, doctors as ICD-11 users is of course challenging because doctors are only interested in ICD-11 as a means for documenting diagnoses. They are not interested in the rules and guidelines for morbidity coding and reporting, which would be of paramount importance if we have a DRG system. So in case of a DRG system, we still need to have experienced, qualified medical coders that would be able to implement these rules and guidelines. But the good news is their time would be better spent doing other tasks, like Vicky just mentioned, validation, like clinical documentation integrity, auditing medical records, and so on and so forth. What's next? Well, remember, ICD-11 was not the target. ICD-11 was a step on the way. And the way was the National Automation Project. Now, after implementing ICD-11 in this hospital, we went back to finalizing our inpatient and outpatient data dictionaries and piloting them in the hospital. This is an ongoing project. We also present our experience to the other public hospitals, to the private sector, which is very minimal of size in Kuwait, and to the primary care services to encourage them to pilot and implement ICD-11. Thank you.